Let me introduce you to Dr. Diego Silva and give you a little bit about his background, and then I'll turn it over to Diego. And I apologize for looking at notes, but I wanted to make sure I didn't leave out a few important details. So Dr. Silva is currently a research scientist at the Institute for History, Ethics, and Philosophy of Medicine at the Hanover Medical School in Hanover, Germany. Dr. Silva received his BA and Master's and PhD from the University of Toronto. He did his BA as a double major in philosophy and bioethics. He then got his master's degree in philosophy and then transitioned to public health and received his PhD from the School of Public Health in the Health and Behavioral Sciences track. He describes his interests as focusing on how traditional political concepts, such as equity, liberty, or harm, are understood by various stakeholders in public health by using empirical research to then further refine normative arguments and inform health policy and practice. He has published many articles, including on topics like ethics and infection control measures, ethics and preparedness, and conducting ethical pragmatic trials with marginalized populations. He will speak with us today on liberty, public health, and the case of tuberculosis. And welcome, we're very glad you're here.
Thank you very much. Thank you very much for that very warm reception. Just before I begin, actually, how many people here are not primarily, or how many people would not identify as primarily from the Berman Institute? Oh, okay, so there's a few. Okay, so some of the material might seem a little repetitious to those who are used to sort of the arguments in bioethics, but I'll still go through them. Okay. So today I want to speak a little bit about the role of liberty in public health, a topic near and dear to a lot of us here, and particularly how it does and doesn't relate to social justice, or what the role of liberty is within social justice. It's a question I've been interested in for a while, both from a theoretical point of view, but also in its sort of applied forms. So the picture that you have in front of you is Delacroix's Liberté guidant le peuple, right? So liberty leading the people. And I want to get back to this in a second. It's not just a pretty painting, but actually, for me, actually has some significance. And not because I'm French or anything. But so just to begin, so just Gosson and Powers, in one of the famous articles, wrote, "Justice is so central to the mission of public health that it has been described as the field's core value. This account of justice stresses the fair disbursement of common advantages and sharing of common burdens, captures the twin moral impulses that animate public health, to advance human well-being by improving health, and to do so particularly by focusing on the needs of the most disadvantaged." And so it's this sort of tradition of social justice, this tradition of justice that underpins a lot of public health. And what I want to argue is that liberty is part of that social justice tradition. And it is in a very nuanced and complex manner. So why did I bring up Delacroix's painting? So it's of the French Revolution, right? And on the one hand, it represents the marriage of liberty, liberté, as part and parcel of what it means to promote justice, right? So throwing off the shackles of the monarchy, the French monarchy, rising up to sort of say, like, these are our rights, these are sort of our abilities as human beings, irrespective of where we stand in social class. But the other aspect that I think is interesting is what comes after the French Revolution, which is the rise of the Jacobins, right? Which is sort of a distortion of what liberty can be. And I think it's sort of an interesting sort of idea, that, you know, when we use terms like liberty, self-determination, autonomy, whatever sort of ethics words we use, that they're not inert, right? That they can be co-opted for, you know, good or bad, broadly speaking, goals. The last thing is, for those who have been in Paris or in France, right, everywhere you walk around, you're going to bump into the motto, right? Liberté, égalité, fraternité, right? Liberty, equality, and fraternity, or solidarity, if you sort of think of a more modern term. And I guess in the back of my mind, you know, what is the relationships among these ideas of liberty, of equality, of solidarity in public health? So in a sense, the thesis is actually quite simple. So one is that the role of liberty in public health is nuanced, complex, counterintuitive. For many of you, this isn't going to be necessarily revolutionary. Neither will the second part, which is liberty, social justice, and health promotion are interconnected. And I want to actually spend a little more time with that idea. In particular, I want to look at this idea that there's this dichotomy between what's good for the individual and what's good versus what's good for the broader public. And I want to sort of ask whether that's true and how true that actually is. And actually argue, like I said, that liberty is part and parcel and goes hand in hand with health promotion. So I'll talk a little bit about liberty and public health theory and practice, and in particular I'll look at, no surprise, John Stuart Mill's version of liberalism and how it applies, more so just as an illustration of what would it mean to sort of look at something in much more, actual theory, much more detail of liberty as opposed to sort of making grand proclamations. But given the brevity of the presentation itself, I'll still not be able to do justice to Mill. And there's actually, as two of your colleagues wrote, an excellent paper, along with so Madison Powers with Faden, Yashar Sagi, hope I pronounced that right, Liberty, Mill, and the Framework of Public Health Ethics. Great paper that actually goes into a lot of detail about what it would mean to look at a Millian framework of public health. And what I want to do is actually touch on some of those topics, but I actually want to move a little bit beyond that into more of the applied aspects of things. So I want to go into a little more detail, and I want to do that using tuberculosis as an example, and then sort of finish off by looking at what would be some lessons for public health more broadly. So again, for many of you, this is sort of political philosophy 101, but I'll still go through it a little bit. So what is liberty? There's as many theories of liberty as there are authors, right? A lot of trees have died on this topic, but it's well worth it. So generally it's assumed that what we're talking about is the ability to make choices that affect and shape your life, in both public and private spheres. Usually most people are going to have some sense of equality tied to this notion of liberty, across different theories of liberalism or different theories of liberty. But the one that I want to actually touch on is this third point. I want to just pause here for a second. So we actually, especially in public health ethics, often talk about state interference, right? What can the state do to interfere with your liberty? There's this presumption of liberty. We'll get to that a little bit. But I actually want to look at also what can the state do to promote liberty? What's the role of liberty in, within health promotion activities? What does health promotion have and can do for notions of freedom? How hands-off, hands-on, that sort of thing. Why liberty? Again, myriad of reasons. It's a basic good, protects us against tyranny of the majority, allows for pluralism of beliefs. And I want to say that, so I currently live and work in Germany. I'm originally Canadian. So you guys can help me out a little bit more on this in terms of liberal values in the US. I see already the chuckles coming. So in one sense, right, oh man, I love all the grins, this is awesome. So in one sense, right, liberty, freedom, plays this fundamental role, right? It's in the UN Declaration of Independence. What I love is the role that liberty plays in many of your satirical newscasts as a, theme that comes up and up again. And again, as a Canadian, I can say I really enjoy this as an export of the United States. But it also plays, there's also all these very real, relevant questions about the role of freedom in current health. So as just one of many examples, the death with dignity laws in America. So I got this graphic from Time, 4 states currently have some kind of 4 or 5 states currently have some kind of legal permission around death with dignity. To what extent is that a hindrance of people's ability to be self-determining? To what extent isn't it? So American public health values fall within the rubric of this broader notion of public values in the United States, right? I think sometimes we sort of think so much in our own silo of health that we sort of forget that public health exists as an institution within the broader edifice of public life. Again, there's this presumption of liberty in public health. And then the last thing I want to just touch on is, again, this notion of limits or restrictions. That a lot of what we write about in public health ethics talks about the restrictions and less so about more so about the limits and the restrictions and less so about the promotions. So this you can't read either at the front or the back. But I was looking at the Maryland laws around tuberculosis. And again, I'm sure many of you know way more about this than I do, so I'd be very curious to hear about this. But in many jurisdictions, there's a distinction between isolation and adherence to anti-tubercular drug regimens. Well, I was actually really curious when I looked at Maryland's law, or the regulation. It says a patient fulfills a requirement of isolation so long as the patient receives adequate chemotherapy, is under medical supervision, and observes instructions of isolation issued by a health officer. So in Maryland, there's this, it seems like this sort of conjoining or conflation between receiving chemotherapy as being part and parcel of what it means to abide by isolation orders. Why that's curious to me is because you might actually think of these as separate things that require separate edicts or separate ways of actually addressing questions of isolation versus chemotherapy in tuberculosis, as we'll get to in a second. So again, sort of repeating myself, liberty is commonly discussed in public health ethics vis-a-vis restrictions. Even I can't escape it, right? Sort of paper looking at smoking bans and persons with schizophrenia, you know. But some people actually move a step further. It's not just that we're talking about restrictions in public health ethics, but that actually plays a fundamental role. So paper by Ron Baird, he writes, clearly public health measured collectively in terms of the lives of individuals on a population basis requires interventions that involve restriction of choice. So it's a clear thing. Ross Upshur, in one of his papers on the principles of public health ethics, writes about the harm principle. The harm principle, as set out by John Stuart Mill, is perhaps the most foundational principle for public health ethics in a democratic society, which is quite a bold statement. So the question is, how true is all this? So what is the harm principle? If I said there's as many iterations of notions of liberty as there are authors, there's just about as many iterations and notions of harm as there are people who write about liberty. Some of the most prominent ones, obviously Mill, Joe Feinberg, Joe Raz. But generally, a sort of a broad conception of the harm principle is something like A is free to do X, and X may be harmful for A, so long as X does not harm non-consenting B. And two very classic examples in public health. One is smoking bans to prevent secondhand smoke, often justified on the basis of the harm principle, and isolation and quarantine for infectious diseases like tuberculosis, which is again why I thought it was kind of interesting that you had chemotherapy in there. So the use or overuse or abuse of liberty in public health and in public health ethics, usually there's some objections, and I would argue that there's at least 3 categories of objections. So one is that liberty is too individualistic of value. And so, for example, Francois Baylis and colleagues wrote, we insist on public health ethics with a very broad scope and an orientation that is thoroughly relational rather than individualistic. So this notion that liberty as a value is just too narrow. Coupled with that is the second objection, that other values perhaps trumps liberty in public health, that we need to think about more communitarian values. So, for example, Jenny, in a paper recently published, talks about the understandings of membership, solidarity, place, and how these values matter in public health, perhaps more so than liberty does. The third category of objections, and one that I tend to fall into a little more so, is this notion that sometimes it's too simplistic, or it's too simplistic how we think of liberty as applied in public health. And again, I note some of the work of your colleagues on this issue. So this is kind of just a reiteration of the thesis. Liberty, if understood robustly, can support these social justice intuitions. So here's the requisite John Stuart Mill portion of the talk. So again, sort of, for many of you, this is sort of old hat, but I'll sort of repeat it anyways. So John Stuart Mill provides sort of a classical utilitarian defense of liberty. Why liberty for Mill? It's going to be something around promoting self-determination, self-direction in one's life. Provides a number of reasons why this is important, including individuality as advancing thinking of individuals in society, so that's a good. This notion of no one is actually infallible, so we want to promote as many ideas as possible. And then in particular, he says, look, there's these three domains of liberty that are particularly important to promote self-determination and well-being. And it might be that we're not actually going to protect all liberties at the same, with the same degree of vigor from a state point of view. So what are the three domains? One is, quote, the inward domain of consciousness. The second one is liberty of taste and pursuits. And the third is the freedom to unite for any purpose not involving harm to others. And here I do quote the paper by Powers, and Mill makes an insightful distinction among liberties that are immune from interference, liberties that deserve a presumption in their favor, and liberties that do not deserve such presumption. So why is this important? Because the idea being that not all liberties are created equal. And that we need, even at this first level, we need more nuance as to how we think about liberty and how we're going to think about limitations to different liberties. So Mill obviously never, well, I shouldn't say obviously, Mill never actually uses the term harm principle, right? It's actually about half a page in his entire book that he kind of talks about the harm principle. The quote on the top is sort of the classic text that's always cited. So why are what justification do we have in interfering with a person's acts? Self-protection and prevention of harm to others. But actually I want to look at this bottom quote. I actually can't remember if it occurs just before or just after the quote above. So you can't compel somebody, but there are good reasons, he says, for remonstrating with him, or reasoning with him, or persuading him, or entreating him, but not necessarily for compelling him or visiting him with any evil. So I think actually this is actually really important, because one of the questions I have is, what does Mill mean for public health, right? And one question I have is, what would Mill look like when we think about nudges, or when we think about health promotion? And it makes me think about the soda, the soda bans, or the size of the soda thing in New York City. So the idea being that, you can get you can go and get more cups of soda if you want more cups of soda, but, we're going to cap the size of the cup itself. And people said, well, this is, infringing on my right to sort of soda. So, set aside for a second what it means to have a right to something like soda, but okay, fine. I guess it's in some ways a right to self-determination. But there's this countervailing idea being that, who's promoting soda consumption, right? How much money is being put into advertisement for soda? Do we have a public health reason based on liberty or based on self-determination or autonomy to actually institute programs that actively countervail such advertisement? And would this be, or would this fall under the realm of what Mill says? These are good reasons for remonstrating. Maybe this is more on the rationalist side. What of things that are perhaps sub-rational? So, Mill actually does deal with some public health issue. And one particular issue is the Contagious Disease Acts of the UK in the 1866 and 69. So Mill, apart from being a prominent political philosopher, was a parliamentarian, which makes me feel really, really lazy. But yeah, so these acts came out, and he sort of came out against these acts. But the justification for, let me go back. So the goal of these acts was to curtail the spread of sexually transmitted illnesses in British naval officers, and by extension, their wives. So what did the law propose? It proposed that sex workers had to submit to examination and hospitalization. It had to allow plainclothes medical police to conduct routine and random general inspections of suspected sex workers. And it had mandated that sex workers be licensed. Now, on the one hand, this seems like it might be an application of the harm principle, right? There's a harm going on, we have a way of eliminating it. Sex itself is not a bad thing, but, spread of disease is, so we're going to institute policies to curb it. Mill rejects this, and why does he reject it? So he says, look, it removes liberty from sex workers and all women, by extension, all women, by treating men and women differently. And the idea is that we actually want men to be responsible for their own actions. And what this shows, or what he argues for, is this notion that it's not that all of a sudden, if there's an instance of harm, you're automatically going to be able to use the harm principle, even under Mill's theory. So Jeremy Waldron wrote vis-a-vis the harm principle in this case. the question for the harm principle is whether the particular impact on liberty is warranted by the prevention of harm. As we have seen, that is understood not just as a matter of quantum, how much liberty is affected and how much harm is prevented, but as a matter of distribution and discrimination so far as liberty is concerned. So that the idea that liberty isn't just this number, and that once you reach this threshold, all of a sudden sort of a harm principle sort of takes effect. And that liberty, not all liberty, that liberty is to be meant to be understood in this sort of equal, egalitarian sense and deserving of equal protection. So switching slightly now to tuberculosis for a second. So what I want to argue is that tuberculosis is a social disease. It's primarily a social disease. So what you have in front of you is a map from the last TB report from the WHO showing the distribution of cases of TB. So just some basic epidemiology. Estimated 9 million incident cases and 11 million prevalent cases of active TB in 2013. About 11 to 14% of those individuals were co-infected with HIV/AIDS, a high rate of co-infection. Unfortunately, 1.5 million deaths globally were estimated during that time, and about 1/4 of those individuals that died were co-infected with HIV/AIDS. About 500,000 incident cases during 2013 were cases of multi-drug resistant tuberculosis, which means that the tuberculosis, different strains are resistant to some combination of first-line anti-tubercular drugs. And what you can see from the map itself is that the distribution of TB is not equally distributed. So 56% of cases occur in the continent of Asia, 29% in Africa, for a grand total of 85% of all global cases. If we look at the United States, and this is taken from the US CDC, it's not the same kind of burden in the United States that it is globally. There were under 1,000 cases in 2013, just over 500 deaths from TB in the United States in 2011. But where it starts to get interesting is when you look at the distribution of TB within the United States. So 65% of reported TB cases in the US occurred among foreign-born persons. But what I really want to pay attention to is actually the US-born. So it says that within the US, when you look at the percentage of cases of active TB, 33% of individuals were white, 37% were black or African American, 20% were Hispanic or Latino. When I did a quick look at the population within the United States, according to census information, 77.7% of Americans are white. Black or African Americans account for 13.2% of US citizens. That is a lot less than the proportion of those infected with tuberculosis. So, globally, TB is a second leading cause of death from infectious diseases. But it isn't all dire news. The first bit of very important good news is the drop in mortality, incident cases and prevalent cases. So between 1990, when we see a reoccurrence of tuberculosis globally, there's been since 1990, 2013, 45% drop in mortality, 41% drop in prevalent cases. And the other actually really good piece of news is that there's better global surveillance. So we actually have a better sense now of what's going on with regards to TB than we did 5 or 10 years ago. So how does TB spread? I love this picture, very dapper looking gentleman, presumably from the 1910s or 20s with a handkerchief delicately to his mouth. So how does it spread? So it's an bacterial pathogen. It's a very slow setting particle, and it's actually quite difficult to catch TB. So you actually need to be in the ideal conditions, physical conditions, to contract TB. So where does TB thrive? It tends to thrive in environments with low sunlight and poor air circulation. It actually requires close proximity and prolonged exposure between individuals in order to contract tuberculosis. So what's the treatment for TB? So there's clinical treatment and public health measures. The clinical treatment includes medications, so the use of anti-tubercular medications, most of which have some kind of adverse effects. So hepatotoxicity is one common side effect of first-line antitubercular drugs. Usually you're taking them anywhere between 6 months and 24 months, so it's a long course of treatment. So as we all know from sort of Public Health 101, when you have these sorts of conditions and people start feeling better as soon as they take a medication, people have incomplete drug treatments, you have creation of drug-resistant strain of TB, which I alluded to earlier. And so for about 40 years, we've been using the exact same class of drugs for tuberculosis. Just recently, at the end of 2012 and the beginning of 2013, 2 new drugs were approved, laminate and bedaquiline, for the use in combination for multi-drug resistant tuberculosis. So it just gives you a sense of the fact that, again, it's considered this disease of the other, right? This disease of low and middle income countries. So in addition to clinical treatment, there's directly observed therapy. Directly observed therapy is when a healthcare worker watches somebody with tuberculosis actually swallow their medications. So they go to their homes, or they find them, they'll sometimes go to their workplaces and, meet in a car in the parking lot, and they'll actually watch the individual take the medication. So on the one hand, this is a public health measure, where we want to make sure that the person finishes their course of treatment so that we try to reduce the rate of drug-resistant strains that are going around. It also has a clinical purpose, precisely because of the adverse effects related to tubercular drugs, or anti-tubercular drugs. We want to make sure that the people are closely monitored as they're taking drugs. Then finally, another public health measure, the respiratory isolation. Oftentimes that means isolation in your home and sort of not going out in public. It can mean actual isolation at a hospital, but oftentimes it just means that if you're going to go outside, you have to wear a mask. And I should say, it's not during the whole course of treatment, it's only until your bacterial count reaches a certain threshold and you're no longer infectious. So the Stop TB program a few years ago, and you can sort of already put the pieces of the puzzle together, wrote this 2-3 page pamphlet on TB and poverty ? And they have this quote that I really like. It's pithy and to the point. TB is a disease of poverty. Why is it a disease of poverty? Well, if you think about the mode by which tuberculosis is distributed, you need to be living or working in very close quarters with other people who are infected with TB. So what are the ideal locations for the spread of TB? Homeless shelters, mining companies, sort of being in the mines, factories. These are all sort of very great places with low sunlight, poor air circulation. A lot of times there's poor or no access to primary care, not just globally, but when you think about the distribution even here in high-income countries. And the last thing I want to note is, again, this sort of this idea that the burden isn't just of disease, but the burden is also of treatment. So if there's an unequal distribution in the burden of disease, the treatment itself, whether it be clinical or having to abide by public health measures, also falls, obviously, disproportionately upon those infected, which are going to be persons with lower SES. I like this quote in this painting. This quote is by Dr. Thomas Frieden, who at the time was one of the key figures in New York during the epidemic in the late 80s, early 90s. He wrote about patients not finishing treatment. He goes, while these patients must accept responsibility for their actions, society must also accept responsibility for creating and allowing to flourish the conditions for noncompliance. Poverty, homelessness, drug abuse, lack of access to medical care, and mental illness. And so, again, what I want to argue, what I think is pretty unequivocal, is that the burden of TB is unjustly distributed. But it's not just unjustly distributed in low and middle income countries, or rather that globally the incidence and the prevalence rate are much more in low and middle income countries, but also that here in Baltimore and Maryland and high income countries, the distribution is also not equal and unjust. So what are some lessons that we can take when we think about liberty and TB? So the first is to say that tuberculosis, you can argue, is unjust on many different theories and for many different reasons. So one is that it produces incalculable and disproportionate amount of suffering Another is that it shows a lack of global solidarity, perhaps. But I want to argue that TB is also unjust because it limits freedom in an unjust way. What I mean by that is, if there's an unequal chance, like I said, of having the There's the burden of disease and the burden of treatment. So there's an unequal chance then, as a correlation, of catching TB and being restricted. And so that too is a wrong. It's not just a trivial freedom that we're talking about in this case. We're talking about having to be taking these drugs with side effects, having to change your life to remain in isolation, having fear of infecting those that you love. So the restrictions aren't trivial. They sort of strike at the very core of freedom. The book that I have underneath that cover is Richard Coker's From Chaos to Coercion. It's a book on the history and ethics of the TB epidemic in New York in the early 90s. And he has a quote, he says, "One common thread runs through all these public health areas: vaccination, immunization, mental illness, and the historical approach to tuberculosis. Coercion began those who were least able to protest or resist: children, the mentally ill, and the poor. And alternatives, unless forced by popular mandate, were rarely considered." So I started off by saying that, look, sometimes we have these sort of counterintuitive senses of what liberty or the role of liberty in public health. And one is, in case of tuberculosis, is directly observed therapy. So like on the one hand, I said it has this dual public health and clinical health focus, right? Sort of protects the individual from adverse effects, let's say, by having somebody monitor their progress. And on the other hand, they're having to, have the somebody from public health make sure they take their medication, right? You make sure they take your medication. There's this parental supervision aspect to it. But what's interesting is that people with TB, might actually feel that both of these things at the same time. So Amy Bender and colleagues did a qualitative interviews with persons who suffer from tuberculosis and persons who worked in DOT. And they wrote, "Surveillance, with its implied limits on freedom and autonomy, is a foundational element of the DOT job. Nonetheless, what formerly was experienced as intrusive visits by public health officials shifts to non-intrusive and even welcomed meetings with a familiar person." And so the title of this paper is actually Welcomed Intrusions. This is the term that they coined based on the themes that they were drawing in their interviews. This idea being that, yes, it's an intrusion, but we're happy that the individual healthcare worker is there to support us. And what I want to argue is, again, that I think this dichotomy between the individual and the others that we often have in public health might be overdrawn in practice. That we need to think about what are public health practices that actually support notions of liberty. And so I want to argue that it's sort of false in two ways, or claim that it's false in two ways. First is that liberty is also about, like I said, promoting health, and health promotion is about promoting liberty, right? So the idea being that the DOT worker who's there to make sure that the person is feeling as good as possible and is able to manage their symptoms is there in part to make sure that the individual is suffering from the least amount of restrictions as possible. The second is, to go back to the harm principle for a second, is this notion of reciprocity. So if we apply the harm principle, and if we're justified in applying the harm principle, we also have to think about what makes the application of the harm principle legitimate. And one of these conditions for legitimate use of the harm principle, or for restrictive measures in public health, justified on the notion of the harm principle, might be this notion of reciprocity. So reciprocity, in an article by Vaines and colleagues, one definition is it's an appropriate balancing of the benefits and burdens of the social cooperation necessary to obtain the good of public health. It requires that one return the good one has received, or responds to harm performed in a fitting manner. So that means, obviously, that if somebody is in isolation, you can't sort of just say, well, you're in isolation, go fend for yourself. But this is actually something that happens in some jurisdictions right now. So when I was doing my doctoral thesis, I was looking at these questions of liberty and the harm principle. But one thing that kept coming up over and over again was although it wasn't called reciprocity, were these examples of reciprocity being fundamental to the work that public health workers do to support persons with TB. So during my sort of conversation with TB workers in Toronto, one person said in an interview, quote, "The resources I wish I had more of tend to be things like access to housing, support, specifically supportive housing. There are no single rooms, even in the shelter system in Toronto. Thousands of beds and not a single one with one bed in one room in the shelter system." Another individual stated, "We don't have the funds to pay people's rents or jobs, but we do get them insured. A lot of our persons come in with weight loss because that's a part of the disease, so we always have Ensure available for them, which is a high protein supplement." So during these interviews, the healthcare workers were describing the various ways that they would support somebody while they were in isolation. One healthcare worker described that their job was to be a cheerleader. As much as they were there to make sure that they're taking care of the symptoms, they were there to cheer the person on. They were there to sort of try to facilitate ways of getting basic things like food. If there wasn't necessarily money in the public health unit, which there wasn't, how could they then tap into the social community of that individual to help them bring food from food drives to try to keep them fed? Again, in Canada, much like the US, it's new Canadians that are subject to a disproportionate amount of TB disease. Again, these individuals are probably the ones that can least afford to stay home at work, right? If we stay home at work, fine, we can still work on our computers and the internet. It's not ideal, but we can manage. But if you're working at a factory, if you're the sole breadwinner for your family member, and then all of a sudden you're told you can't work, you're disposable, what does that mean? So I want to argue that we shouldn't fixate necessarily on the restrictions, that we need to actually think about what it means to promote liberty within public health. We need to think about, in the case of tuberculosis, what are some of the ways of promoting liberty and social justice in TB care? So again, thinking of reciprocity is one way, thinking sort of concretely about how we can support public health care workers that then support the individuals with TB. But the other thing is actually to think even more broadly, in terms of how do we fix the actual conditions that cause TB in the first place. So again, there's many reasons why we want to eliminate poverty. TB is just another one of these sort of interconnected reasons. Again, in one way, TB is sort of symptomatic of the larger ills around issues of poverty and income inequality. So just some concluding remarks. Again, sort of repeating myself now, but this idea of liberty being nuanced, complex, and counterintuitive. Liberty is a fundamental value of public health and vis-a-vis this notion of social justice. But I just want to draw home again this notion of health promotion as a means of promoting fundamental liberties. So there was a project that I worked on recently. It was called At Home Chez Soi. So what it was a project looking at providing housing support for individuals with mental health issues. So these are people with severe mental health issues. And it used the Housing First model, which actually started in New York City. And the idea behind Housing First model is usually for most programs with persons with mental illness, if they have substance abuse issues, which is a lot of comorbidity with that, you need to get mental health support first before you're going to get housing. And Housing First flips that. It says, okay, the first thing that we're going to do is we're going to find you a good, stable home that you can live in, and then we're going to be able to sort of treat the symptoms. And it got me to thinking, okay, well, why this project? Why are we doing this project? Why am I part of this project? And again, like tuberculosis, there's a lot of reasons that homelessness and mental health are bad things, right? But one of these reasons is that if we look at the impetus behind deinstitutionalization in the first place, back in the 50s and 60s, it was this notion of, well, what we want to do is allow people to enjoy their civil rights in the communities. And this includes people who are often stigmatized, like persons with mental illnesses. And to me, this project, as much as it is about a myriad of other goods, one of them is to sort of continue that notion, continue that sort of the spirit of actually protecting and promoting people's liberties through public health interventions. Thank you.
Great, so we have between 15 and 20 minutes for questions, and floor's open. I'm assuming you can field your own questions as you see
Sure.
the hands.
I have a question. I can start. Earlier on in the talk, you had a comment about the Maryland law about isolation. It said that if a person is adherent to the chemotherapeutic regimen, it sort of counts as part of the isolation. And you said that was surprising to you or interesting, and I couldn't, seems to make sense to me, so I wanted to know a little bit more about why you found that interesting.
Yeah, so usually they're taken as two different steps. Do you adhere to isolation, and then do you adhere to drug treatment? And the reason being that it could be that you say, a person with TB says, look, I'll isolate myself, but what I don't want to do is take these nasty medications. And why not? Because I think they're toxic, because I think that I'm better off trying to fight the TB, let my own body sort of fight the TB with sort of good air and fresh food, which is, you know, part of what they used to do in sanitariums. And so you could conceivably have somebody who would abide by isolation orders and not necessarily treatment. And at least in Canada, and I know not just in Canada, but there's been cases which says healthcare workers, you know, will say, we're fine making sure we police questions of isolation. So if somebody is not abiding by isolation orders, we're perfectly fine having the police pick them up and taking them to the hospital and making sure they remain in isolation. But you're going to have a lot of trouble finding healthcare workers. I would say probably in a lot of places that would say, yeah, we should also actually force the medication on somebody. For a number of reasons. One is sort of because that's an extra step that you're then taking against the person's body. And then also because it might not be as easy as all that. But again, this idea that we might want to separate isolation from the actual chemotherapy itself. And that's why I thought, again, I don't know if anybody else has more information on that, but
I was going to raise, I think you misread our law.
oh, okay.
Because, in fact, they are separate.
Okay,
So I
perfect.
used to be the medical director for the tuberculosis program in Baltimore, and we had a number of people who were forcibly isolated
Okay.
in correctional facilities or in nursing homes that they couldn't leave.
Okay.
But nobody was ever forced to take medication. They were convinced to take medication because their isolation couldn't end. And
Right.
the thing in the Maryland law that is perhaps more draconian than in other places is that a judge can order someone to be isolated and not freed until they're cured, as opposed to when they're no longer infectious. In most places, it's only when you're no longer infectious. But in Maryland, a judge can decide that you're going to be, you know, in prison or in a nursing facility and you can't leave until you're cured. But nobody is forced to have treatment. And I think the wording, you've read the law more recently than I have, but I think the wording is that when you're in isolation to prevent transmission, by being on treatment, you're fulfilling the requirements
I see.
of
Okay.
the goals of isolation. That's my take on it.
Okay.
But I can tell you that those are two separate things, and no one's ever forced to take medicine.
Right, that would be in keeping with how I understand it, so yeah, I probably misread it.
Hi, thank you for a great presentation. I was just curious, when you were talking about welcome intrusions, and also pairing off with the way Nancy sort of introduced your interests, it sort of got me thinking about, you know, we can sort of document that people who get TB treatment and also get these protein supplements and things like that are receiving a benefit. But if those people don't perceive it as a benefit, as welcome, is it still a welcome intrusion? I'm just sort of wondering the role that you view sort of getting that empirical data that these people do perceive that as something they want, how that factors into your sort of normative analysis of it.
Yeah, I think that's a great question. I think that it does matter a little bit what other people who are receiving this treatment think.
Yeah.
that doesn't mean that what they say is sacrosanct, right? There might be reasons why people want X and it's not in their best interest, but I think that if they see it as a welcomed, as part of the welcomed part of the intrusion, then I think it at least gives us impetus to think more carefully about what's the nuanced way to think about this treatment option. What I think is interesting is that the protein supplement is a bit of a different case, actually, because that's not part of directly observed therapy necessarily. The idea being that people are in isolation, they're suffering from the tuberculosis. How do we ensure they remain in isolation? Because instrumentally we want them to stay in isolation, right? So it's health promotion by carrot as opposed to health promotion by stick. But it's also this notion that people who are voluntarily sort of taking on isolation orders, which means that they have other hardships because of that, should then also be protected as part and parcel of doing the right thing, because that's what we owe them, so to speak. But it's a bit different than the directly observed therapy itself. But with regard to the directly observed therapy, I would say again that I think that we need to sort of do our normative analysis, knowing that there's sort of a piece of empirical data is out there, and sort of have that be part of our calculus. Not necessarily an overriding part, but I think definitely something to be considered.
So, terrific talk, thank you very much. So my primary field is injury prevention, and so we run up against the harm principle, and typically in the context of people accusing us of saying, for example, in the context of motorcycle helmet laws, that you are forcing the individual to do something that protects themselves but causes no harm to others.
Mm-hmm.
And the way that courts have reacted to that argument is by extending the definition of what counts as harm, basically. They've said, well, if I don't wear my motorcycle helmet, which you should believe me, the people who don't want to wear their helmet believe is a deeply, deeply felt intrusion on their liberty. That the way that harms others is in this more indirect way, that it costs society money to scoop them up off the road, that their children might be orphaned, etc. So I've always been troubled by that extension of the definition of harm in order to sort of, in some ways, get around the harm principle. I'm curious what your reaction to that.
Yeah, I would say that, again, there might be, the harm principle is one way of instituting restrictions on actions, but that by extension restrict freedom. It need not be the only way. And there might be other justified reasons why we have laws like helmet laws. So I would say that I understand the argument of saying, well, it costs money to have them in intensive care units, it costs, undue hardship to, their children, and those sort of incidental arguments. I just don't think that necessarily it should, that I'm with you, that I don't necessarily think that it's the harm principle per se that should be used. You could justify it on other dimensions, and again, I'm sort of open to what those arguments may or may not be, but I sort of share your intuition that there is sort of limits to perhaps how far we can extend certain normative ideas.
Thank you.
Hi, thanks for your talk. I wanted to follow up on, you sort of dropped, or mentioned, I should say, early on this idea of thinking about relations or relationships or relational issues. And I'm wondering, both of these examples seem to me to devolve at some point to saying, at some point it might be a welcome intrusion because I've developed a relationship and appreciate that this person cares for me or isn't acting in my best interest, and in the, like you ought to think about who you're related to and how that may affect you. And I'm wondering, in your reading, us, meaning the U.S., I often think of the Canadian sort of public health literature focusing more on that particular aspect, and I'm wondering how you might incorporate that into this argument about being careful about liberty and how you're using that terminology.
Yeah, I think that it depends. So I think that's a good question. Let me try to answer it one way. You can tell me if I answer it or don't. So one question is how foundational is this idea of liberty in the first place? So is it one value amongst other values, or is it a value that then spawns other values itself? And it might be that sort of we want notions of relationality to be on par with conceptions of freedom, or it might be that there are certain instances when we want a very thin notion of freedom, sort of a very sort of negative notion of freedom, and then there might be instances when we want more robust ideas. And it might be that in public health we want some of these more robust. Now, in terms of Canada versus the US, that's an interesting question. I haven't really given a lot of thought about sort of the comparison between Canada and the US. I would say that you know, at least at first blush, it's not that different in terms of when you look at the actual laws and policies from Health Canada compared to the CDC, or you know, but it might look different in the context of each country, perhaps, is where that difference might be. But again, the devil's in the details, and I think sometimes, you know, I'm just trying to think. With regards to reciprocity, for example, as sort of a value that we need to sort of couple with you know, limitations on freedoms, the Canadian public and some of the work that I've done with a group looking at pandemic influenza planning, there's this, you know, strong emphasis on, you know, there's certain, if people abide by isolation orders, or healthcare workers who are taking, you know, extra risk during pandemic influenza or stuff like that, that we owe them special consideration, and we owe them, you know, either debts of gratitude or stuff like that, so that there are sort of other values that sort of are coupled with. And I think that sort of similar responses were found. I'm trying to think, it was a group out of Minnesota that I think did empirical work on pandemic influenza as well. I think they found actually similar.
They're awfully north.
Pardon me?
They're awfully close to Canada.
It's even colder than Toronto, right? So yeah, maybe it's a cold weather. Yeah, so I think that the sort of comparison between Canada and the US, it would just depend on the case. Yeah.
Thanks.
Thanks for your talk. It's great to hear, and I used to travel in bioethics circles, but don't as much anymore, so it's nice to be back a little bit. You know, one thing that I was a little curious about is, you know, your claim that TB is unjust, and I guess I didn't, you know, I don't think of a disease as being unjust. It sort of strikes me as like thinking about like alcohol as being evil. You know, alcohol is not evil. Some people use it badly and things like that. So I guess I'm just wondering if you could elaborate a little bit. I think there's more behind that, but I'm just wondering if you can kind of parse out what you mean when you make a claim that a disease itself is unjust.
Yeah, great point. So I don't think that TB, the actual mycobacterium tuberculosis, is an evil thing. So I agree with you there. What I guess meant to say, or sort of what I was trying to get at is, what I didn't articulate was the theory of social justice. Completely absent, right? And so what I would argue is that on most theories of social justice, pick your theory, the facts about tuberculosis is going to be such that you're going to find it to be unjust. But what I didn't do is, again, articulate the theory of social justice. But I would say that you're going to, again, you know, depending on your perspective, whether you're saying that, you know, justice is fundamental, you know, you take a Kantian juridical account, you know, where you have this, you know, self-determination or self-mastery as being the foundational value upon which all other political values are built upon. That you have something that is unjust in its that is unequal in its distribution, based not on factors of the biology of the disease itself, but based on social factors that we can control, then I think it's going to be considered unjust. So Kant has an argument in favor of free distribution of wealth that I think would actually get at the heart of causes of tuberculosis in terms of poverty and stuff like that. So all this to say that I absolutely agree. I glossed over that part because what you would need is a theory of social justice in order to animate that part. But I would say it's overdetermined. Sorry, I'm not ignoring it.
No, go ahead, because I've got more chances.
I just wanted to ask you about directly observed therapy and ask you to speak more about it, because I think you talked about isolation and DOTs as related burdens of tuberculosis. The isolation part, frankly, is pretty trivial. For almost everybody, it's not going out of their house when they're very sick anyway. And it can be, if you do go out, wear a mask, and that's the isolation. So for the most part, it's not very burdensome. But for some people, they go to prison, so I'm not denying it.
Yeah.
But directly observed therapy is burdensome to everybody, and it's universally applied in this country and in other countries. It's not universally applied in countries that have the high rates of TB, which is unfortunate. And the
Often due to resource issues.
yeah, but the reason that it's used is because it works, and the outcomes are better. And policies are based entirely on outcome data at the public health level.
Right.
But it's burdensome, and so to me that comes across as saying we're doing this because it's good for you, and you don't have a chance to say no. And I'm comfortable doing that because it works. But I just wonder what you think about that. You can give all the ensure you want, but
Right.
we're making you show up here or be available so we can put these pills in your mouth and watch you swallow them. And we're doing it because it's going to make you a better person. You're going to survive.
Sorry, I was sort of taking down notes. So, you've worked in TV and I haven't, so I'll defer to you, but I'm actually not entirely convinced that isolation is so effortless. So, for example, there is literature that suggests that even going outside with the masks, you're automatically another, right? So you're all of a sudden conscious of the fact you're wearing a mask, and people around you are conscious of you wearing a mask. So I don't know, I personally, I hate it, but when I see somebody with a mask walking down the street, I do this, right? I mean, it's just like a knee-jerk reaction. I'm pretty sure someone who's wearing the mask recognizes everybody doing that. The other question is, even if you're in your house in isolation, depends on how long you might be in your house in isolation. You're right, you might be very sick, but you also might be thinking, man, my wife or my significant other or my loved one is bringing food to me. I really hope I'm not, being a source of TB for them. So one concern that at least I've been told and I've read about is transmission within the family. To the point that even after certain, measures are taken, like uses of air filters, making sure that the space is such that they can actually be housed in their own homes, people will remain in self-isolation for a lot longer because they don't want to infect their family. So, I mean, I guess I'm not entirely sure how innocuous isolation is psychologically on people. So I guess that's sort of one question. But again, you worked in TV and I didn't, so I guess I'll defer. But the other question is, you said sort of, we do DOT because it works. And take these pills because you'll survive, right? There's not a lot of areas of healthcare where we use that logic of, we're going to sit and watch you take your medications because you're going to survive, right? Usually the motivation for doing something like that is because you'll survive, and if you don't take it, you're a danger to other people. Is that correct?
Mm-hmm. Yeah.
And so there is this sort of it's not just because it's good for the individual that we're making them take their medications, it's because it's good for others. Okay, so I guess what I'm wondering is, I didn't get the question then on that second part.
Well, I think we use, I mean, it's like the motorcycle example, you know, there are all these other good reasons for society. But if you look at, the original recommendation from the CDC to use directly observed therapy was on the basis of a paper we published here in 1994 showing that people with AIDS and TB who got directly observed therapy had much better survival. And that was the reason. Now, it had nothing to do with transmission. It was you were more likely to survive if you got directly observed therapy. The CDC, within the year, recommended that all patients with AIDS and TB should have directly observed therapy because it would survive longer. And then the wider application of DOT was based on Baltimore's experience with having better outcome rates and having a reduction in TB incidence in the community at a time when TB was epidemic. So it was both individual and public health.
Right.
So I'm not. I was sort of overlooking the public benefit stuff, but sort of along the lines of, if you die in a motorcycle accident, there's going to be a lot of public resources spent on you. But fundamentally, what drove it was that the patients will do better, and we're doing this for your own good and for our good, but for your own good.
Yeah, I mean, again, I've read accounts that argue that the primary purpose behind DOT, regardless of why, whatever it says on the books, that why we're doing it is for this public aspect of it. And the difference between the motorcycle case and tuberculosis isn't that in both cases you're using resources, so it's burdensome to the public healthcare system, or to the health system, to invoke DOT the same way as it is to scrape somebody off the street, right? Use that image, but
We use it.
pardon me?
We use it too.
There you go, it's evocative, right? But rather that there's a burden which, is harder to quantify, which is you're causing physical harm by the spread of TB infection and then cause of TB disease in other persons, right? It's not just a cost to the healthcare system, it's a cost to somebody's well-being and health. So again, I mean, that laws and policy were written with regards to saying, okay, well, we'll invoke DOT because, it helps with cure rates. That's all fine and good. But I don't, again, not a scientist, but I think that you would actually improve cure rates in a lot of different things if you, use DOT, but it's not used commonly. Right? So I just think that, there's a bit of a disanalogy, I think, between tuberculosis and the case of instituting DOT for motorcycles, or instituting the harm principle for motorcycles. Yeah.
Let's have Jim's question be the last one, because we're a little over
Sure.
time.
I come from an African country where there's a lot of TB, possibly HIV/AIDS, and I'm just wondering how, what you think of this, that when you have TB, by the time you get active TB, that you're really sick, your immunity is really low. So it's not really, okay, so one issue is they're protecting you when the public says we want to have you in isolation. They're protecting you, they're protecting the public. But what do you think of you being protected from the public? Because, like, for example, the world map that you showed us, when there is TB, like, for example, in Africa,
Yeah.
so many other people who are going to be moving around in the public, and they actually have TB. So by you being isolated, you're actually being protected from those other people, especially that your immunity is very low.
Yeah, I think that's a great point. I think in that case, the isolation has very much a clinical focus in that case. The question is whether it always has this sort of clinical dimension. But I think you're absolutely right to point out it does have a clinical dimension, especially in the situation that you're describing. And in that case, yeah, I mean, we want to protect individuals with lower immunity from co-infections or from other ills that might come about. So yeah, absolutely.
All right, sorry we went a few minutes over, but clearly there was a lot of interest. Thank you.